Hey guys, welcome back to the channel. Today's video is about FAI, Femoroacetabular Impingement. We see it in a lot of our athletes. A lot of times these are results of bony malformations in the hip, but a lot of times these are things that we can deal with outside of surgery. I'm Max Wardell from overheadathletics.com, and today we're going to talk about this hip impingement. Here's a pelvis. When we look at athletic movements, particularly throwing, we see a lot of hip hinging and flexing over the back leg. So a flex forward of the pelvis, internal rotation, which is that rotation away from the target that keeps you closed, and then what we call hip hike. So the front aspect of the hip hiking higher than the back aspect. Now we can sometimes see the loss of these motions as a result of weakness or poor control in these ranges, but we also can see them as a result of bony malformation, either on the rim, which is known as the acetabulum, or the actual neck of the femur as we get into the ball and socket. So if this neck kind of distends out and is too wide, we can see some difficulty abducting the hip because bone contacts bone and we lose that range to move. So as a result, we get impingement, we get pinching in the front aspect of the hip, sometimes the outside of the hip. I have a 10-inch incision on the outside of my hip where I actually had a hip surgery from about here to here where they actually dislocated my hip, repaired that. Likewise, on the other side, I have a bit of a cam lesion, bone spurring, which is basically where that bone is overgrown a little bit and is pinching in and compressing on the hip. If you think about the hip joint, we think about one aspect, we have this kind of coating around the hip, which is known as the capsule of the hip. So the ligaments of the hip, which are the thickenings of the capsule, can restrict our motion in multiple directions, just like musculature can, or bony anatomy can. If we're dealing with bony anatomy that's limiting us and not letting us move in certain motions, we have to get the most that we can out of the other motions of our hip. You can see on the screen what it looks like to have a normal hip compared to a cam lesion, which is thickening of the bone on the neck of the femur, compared to a pincer lesion here in the middle, which is a distension of the bone outwards actually on the socket. And so the hip can't move through its normal arthrological range. As a result of these, sometimes we get some thickening and tightening or stiffening of the capsule that we have to work through. We have to be careful that we avoid pinching movements because that's going to exacerbate or make the hip worse. We got to make sure that we move in a pain-free range and get as strong as possible in the muscles that attach from here to here of some of the hip abductor and smaller gluteal muscles. Likewise, the more motion we can get in a pain-free direction of the hip, the more capacity our hip has. So if our hip hurts, bringing the knee up to the chest, but we're pain-free in extension of the hip, we're going to spend some more time initially in extension of the hip to open that hip up with the hopes of maybe allowing this to calm down so I can access hip flexion later on. In the next phase of videos, I want to talk about how we can start to train the hip abductors to be as strong as possible, and then talk about how we can begin to mobilize the hip and gain extension, flexion, internal rotation, or external rotation, depending on where your hip is limited and where you feel impingement. A lot of times we'll get impingement in the front. People think that they have a hip flexor issue because it hurts right where that hip flexor is. But if they're bringing the knee to the chest or if they're squatting down and they're getting pain in the front of the hip, that's not a hip flexor issue, that's a hip impingement issue. If you have pain going into extension and you have pain in the front of the hip, it's potential that that is a hip flexor issue. And we're going to parse through that in the very next clip in this video series. We'll see you guys in those next 3 videos, how to assess, how to strengthen, and how to mobilize your hips. We're going to show you one of our favorite hip assessments that we start with because it's going to tell us a little bit about your ability to access hip extension as well as the flexibility and extensibility of the anterior hip and thigh there. Think about your hip. We have some cardinal plane movements. Extension, the ability to move backwards with the leg. Flexion, the ability to come up. Abduction, out. Adduction, in. Internal rotation, in. External rotation, out. So external rotation, turning the leg out or the knee out. Internal rotation coming in. And these can happen as a result of the pelvis moving on a fixed femur, i.e. the leg's not moving and the hips are, or it can happen as a result of the femur moving on a relatively fixed pelvis. Let's assess that hip extension to start. Knee to the chest, let yourself fall back on the surface. You're pulling this knee up, you're letting this one fall to the floor, and what we should see is that we get good contact with the table. We get the leg to be able to hang virtually vertical. And what we'll see in the majority of our athletes that come in is when they pull this knee to the chest, they end up extended out where this leg can't contact the table and their leg is extended. And what we should see is that they should fall pretty effortlessly down. Now, likewise, in this position, they should be able to flex their hip. And you can see this is a hip that I actually have a cam lesion on. I don't have a lot of hip flexion. I have good hip extension over here, not great hip flexion here. Opposite leg, which I've had surgery on, you can see how much higher I can get that to my chest. I just don't have that ability because I have that extra bone in the hip. If I find out that I'm limited and I can't get into this motion at all, the leg is extended, that's telling me that the front system of my hip is too stiff and I need to stretch it. Now, likewise here, if I feel an intense burning or pain in the front of the hip up here, there's a chance that I may be dealing with some length issues of the iliopsoas or of the rectus femoris, which mean I might actually have a hip flexor issue. If I'm pulling the knee to the chest, feel pinching in the front, that's certainly not a psoas issue, especially if I'm using my hands. And if I have pain going to the bottom of the squat at various angles here, and I'm pinching in the front, that's a sign that I'm dealing with a bit more of a hip flexion issue and femoroacetabular impingement where I'm getting into the front. And in video 2, we're going to show you guys how to mobilize that. Video 3, we're going to show you how to strengthen your hips so they don't get into those same impingement positions anymore. And that's our 3-part series here. This is our first assessment. What I also like to look at is a straight leg raise on the back to actually look at hamstring flexibility in my athletes. And what I'll see a lot of times, and you may notice it on me right now, is that the left leg is less flexible than the right, and the result is because of a pelvic obliquity. You should see about a 90-degree angle minimum here. If I start to come up and I get stiff and stuck, that's a hamstring deficit that I'm going to start to train. One of the interesting things that we can start to do with our athletes is look at hip internal rotation, and we've looked at that before. And the easiest way to start to look at that is to sit off the edge of a table and look at how far out I can get in a 90-degree position, and then how far into internal rotation I can get in an extended position. Sitting off the edge of a table, 2 fists between the knees, how far out can you rotate? Now in a 90-90 position, 90-90 at the knees, I should be able to see a total arc of motion, hopefully of at least 75 degrees, preferably closer to 90. You see I definitely don't have a lot of internal rotation here, and I'm pretty stiff this way as well. Now I bend one leg, and I should be able to come actively into this motion. Now if I had a therapist or a super friend to add to this assessment, I could look at, okay, how much can they do passively? But you see I'm really limited on that left hip that's got that extra bone going into external rotation. You can see my arc of motion is nowhere near 90 degrees. From there, what we like to do is look at the same exact thing on our back and see if there's an obliquity or an asymmetry side to side. So now we're looking at external rotation. I'm doing my right leg here. I got my arch right at the knee, and I'm coming out. And I should be able to see that this leg can get close to the table and fall into that position. Now let's look at my left leg. And this is where I'm really limited. You saw I was limited in external rotation, sitting on my butt in the 90-90 position, which is with more hip flexion. Now I'll do this frog leg position coming out. I get a big pinch in the outside of my hip, and that's as far as I get here. So we know this is my position of restriction. Now this is not a muscle limitation that you're going to stretch through, and I know I'm already going to get comments about that, and I'm probably just not going to respond to you because you're not going to stretch this. This is not a muscle limitation. What you can do is mobilize the joint a little bit to allow yourself to get into a better position. But that's as far as I get a pinching there. So if we look at my hip, we can see that I'm a little limited coming into flexion on this left side, definitely limited into external rotation. I'm fairly symmetrical with internal rotation rotating out, but I can go much further into the range with no pinching here on the right leg. Now let's assess hip extension. We're going to go into our last two assessments, which are going to bias us into hip extension. What we're trying to do with these assessments is determine where we're stiff so we know where to mobilize and also where to avoid if we're having pinching. We know if we're getting pinching into flexion, we're going to stay away from that and go more into extension. Here what we're doing is an extension assessment. Leg is straight. I'm on a furniture slider. Use something on the carpet at home, something on the hardwood floor that slides pretty easily with a low coefficient of friction. The front leg can bend, the back leg cannot. My butt is tucked under, so my back is flat. I've got something to hold on to if I need it. As soon as this knee starts to bend, that's the end of the assessment. As soon as my back starts to arch and I lose my core stability, that's once again the end of the assessment, because I'm looking at, do I have control of my end range hip extension? When I start to lose it, that's the end. Now, do I feel a stretch in the front of the hip? Do I feel a pinch in the back? If I feel a pinch in the back, that's indicative of hip impingement posteriorly. If I feel a stretch in the front, and it should feel like a stretch, not a pain, that's indicative of tightness in the front of the hip, whether that's the capsule that we talked about in the beginning or those muscles, those hip flexor muscles coming back. Now looking at the right leg, just significantly less stretch. Nothing posteriorly in the back. That's where I start to get it. And it can come on back. Now this is actually an exercise we can use as well. But that's how we like to start to look at hip extension globally. And then we can do the same thing. Tuck the butt under, bend the knee, rotate out. How far can I get? Okay. How far can I get? Oh, a lot farther. So we know I'm stiff in internal rotation, a little stiff in extension, but I don't feel any impingement there. Likewise, leg up, turn in, that's pelvis, rotating in on the femur. Rotating out, external rotation, I'm rotating out, external, in, internal, in extension, out, external, in, internal. All right, so now what have we identified here? We've done a lot of different assessments because your hip moves three-dimensionally. And I wish I could simplify it even more and just say, here, assess this one thing and give yourself improvement. But what we've kind of done here is we said, okay, we want to assess how the hip moves up here. With how the hip moves back here, can we get up? Can we get back as our cardinal plane motions? And we can always start to assess motion laterally. But that's really something I start to work on later once I've addressed flexion extension. Because we'll see people that have a problem with hip flexion, so they have a problem with internal rotation and flexion, but they have no problem with internal rotation and extension down here. So if I had pain in any of the assessments, it's going to tell me something. Was my hip flexed, meaning my knee coming up? Was my leg turned out, meaning the ankle in, knee out? Or ankle out, knee in? So internal rotation, external rotation. If one of those bothered it, I'm going to try to stay away from that, mobilize in the opposite direction. What we're going to show you here in our next video in this series is how to take your findings in these tests, painful, restricted, asymmetrical, whatever it is, and look at what we can start to do as far as mobilizing those things for your hip, and then strengthening your hips in general so you can be a little stronger through the full arc of motion. You should be able to manage these things at home. You shouldn't need to always have to see a surgeon, physical therapist, whatever. We want to reserve those positions for, hey, I've worked on trying to manage this thing. It's getting worse. It's not getting better. I'm not seeing the results I want to get. Now I need to see a movement specialist first, physical therapist. If they say, hey, you know what, let's triage this. This is going to be an orthopedic surgery case. Then we go from there. But let's start with trying to assess some things on our own, try to work through some things on our own, and have the ability to manage our own issues as individuals and as athletes. If you like this video, hit the thumbs up. We'll see you guys on the channel in the next video. And if you have any questions or things aren't making sense, drop them in the comment section. I know we went through a lot of different assessments. We went through our modified Thomas test to look at the flexibility of the front of the hip, straight leg raise to look at hamstring flexibility, often a low-hanging fruit. We looked at a bent knee, internal and external rotation. We looked at our frog leg, external rotation. We looked at our hip extension slide, and then we looked at our active hip internal rotation, and then pelvic on femur external and internal rotation. Take those findings, write them down. We'll see you guys in the next video on mobilizations.